My first case is a bullous hemorrhagic retinal detachment. And there are few things that we should keep in mind. Like this was a case, so because you're not able to see the cannula at first, you have to use the anterior chamber infusion. And once you are able to, just put on the volume.
Vitreous in these cases, as it is hard to differentiate it from underlying detached retina. Total retinal detachment with massive subretinal hemorrhage was seen once the vitreous opacities were clear. Endodiathermy was done in the temporal peripheral retina in order to perform a large drainage retinectomy. Initially, the bulk of subretinal blood was aspirated through a small retinotomy using a brush needle. This prevents overspill of blood in the vitreous cavity, thus obscuring the view. Retinectomy is then extended and the retina is flipped to reveal the subretinal space. Remaining subretinal blood is then removed slowly using backfresh needle. Large clots are removed using vitreous cutter. One needs to be patient and remove as much blood as possible. This may sometimes take a lot of time and multiple attempts are needed for complete removal. Once sufficient amount of blood is removed, then retina is flattened using perfluorocarbon liquid, and endolaser was done around retinal breaks and a 360-degree varage laser was done to peripheral retina. A direct PFCL silicone oil exchange was performed. 4 months post-operative, the retina was attached and the visual acuity had improved to 6/36. Silicone oil was removed at this stage. 3 months after removal of silicone oil, the visual acuity improved further to 6/18.
So few things I would like to highlight is, like, one thing is you can use the anterior chamber maintainer or an anterior chamber cannula if you're not able to see the blood in front, or if you're not able to see the infusion cannula that you're using. Second, this hemorrhage and this RD, when you see that, when it's such a dense hemorrhage, sometimes you're not able to differentiate whether you're cutting the retina or you're cutting the vitreous. So just keep your cutter, the port of your cutter always visible, so that you can avoid creating inadvertent breaks while you use cutting the vitreous. And third is, once you have removed the vitreous and when you are creating the retinotomy, just create a smaller retinotomy first and remove the the bulk of the subretinal blood. Because if you try to create a larger retinectomy, the whole of the subretinal blood will come in front and will obscure your view. And then you will have to spend a lot of time just to get a good clearance. So these are some points. Otherwise, then the surgery just becomes like a giant retinal tear once you have done it. My second case is this 36 years female, best corrected vision was 6/36. She was a known case of angiomatosis, exudative RD, and macular edema. She had an exophytic angioma in the inferior temporal quadrant, and she had undergone multiple sittings of laser and cryo for the past 2 years, even multiple injections of intravitreal Ozurdex to control her macular edema. And after 2 years, we thought, like, we'll just now do a surgery because she was having a recurrent macular edema. This was over the course of this year. You see, the edema was recurrent, and it was coming again and again. So after 6 injections, her best corrected vision had fallen to 6/36, and the edema was still persistent at this stage. So at this stage, we advised her, this was 13th March 2020, and unfortunately, the lockdown came up at this particular time only. And again, we couldn't, then she came after 3 months, and then we did the surgery, sorry. So this is a 25 gauge vitrectomy, and now we removed the vitreous. So when I plan for a large retinectomy, I always plan for a vitrectomy with base shaving. And you see, there was an epiretinal membrane which was taken care of. The ILM was peeled. I wanted to make sure that all membranes had been removed. Because these patients of angiomatosis, they will have very multiple membranes at various levels. So you have to take care all these membranes are removed. And then these 100% endodiathermy burns were given around the tumor. I planned to do only a retinectomy and excision of the tumor, but I only realized that the tumor was too adherent to the underlying choroid. So we converted our plan. We had to do a chorioretinectomy at this stage. I think Dr. Guha in his presentation highlighted on the procedure of chorioretinectomy. So just let us revise it. We give 100% burns and diathermy burns. You see, it was so adherent to the underlying choroid. So we are not doing a chorioretinectomy. We are removing the tumor, the retina, the tumor, and the underlying choroid till to the level of bare sclera. And you see, if you have given 100% diathermy burns, you don't experience any bleeding, as you see in this case. There might be some bleeding, but it can be easily controlled. So excision of this tumor was completed, and then a fluid air exchange and gas was used as a tamponade. This diathermy was just to confirm whether the whole of the choroid has been taken care of. Then the laser, in this case, we did a laser around the chorioretinectomy, and also 360-degree prophylactic barrage was done. And gas was used as a tamponade. This is 6 weeks post-operative. Vision acuity had improved to 6/12. She was doing well, and she had never had a recurrence after this. So that was one benefit that we had. This is my last case, 360-degree giant retinal tear with closed funnel RD. Dr. Goa has shown his cases, but this was a totally crumpled up retina. And there was a small attachment in the periphery. I thought I'll not touch this attachment till I take care of the PVR. So I started with removal of these subretinal bands. You can have the audio if it is there.
Membranes at the edge of retina were removed carefully one by one.
So when there is a crumpled up retina, there are always the membrane is, there is an edge of the membrane.
Posterior membrane which was causing inward contraction of retina was grasped at the posterior pole and slowly removed in a single piece, thus releasing the traction on the retinal surface.
So when it is crumpled up, it is always good to just go posteriorly and you try to remove the membrane as one piece. And it will come very nicely. You will be able to remove whole of the membranes in just one piece. You won't have to do a separate then dissection of each and every membrane interiorly.
Once the optic nerve head was visible, heavy perfluorocarbon liquid was used to open the funnel and flatten the retina.
So I did not remove the attached part.
Folds over the retina were straightened using diamond duster Tano's membrane
that
scraper.
gave me a little leeway in that the macula oriented into a normal place. Then once I had put some PFCL, then I cut the attachment.
Chorioretinal scar to bind the retina with the underlying choroid.
And here I have given a large, heavy burns. I'm creating a new aura for the
silicone oil tamponade was done. Silicone oil was removed from the eye after 4 months.
This was a patient who had injury due to a leopard striking his claws in the eyes.
Of 6/36.
Thank you.
Amazing videos as usual. So for this last case again, did you experience any hypotony after this?
No, actually, I cut this video short. In fact, I should have shown that. There were a lot of membranes in the ciliary body. I removed all those membranes also during this.
So you didn't experience any hypotony?
No, we didn't. We were able to, in fact, I cut this video short. We removed the silicone oil after some time.
So very nice videos, Dr. Sangeet. I think for me, the last case, probably I would have just said best left alone. But now I know where to refer these cases.
No, I think we are all capable of handling these cases. It's just like, just to say that never say never to anybody. There is always a chance.
Sangeet sir, how do you ensure that the choroidal vessels are also cauterized before you do the chorioretinectomy?
So once you do a 100% burn and just go deep and just keep on, you don't move your diathermy like this.
Okay.
Just go deep till you touch the sclera, one by one, then this you can create.
First case, what was the reason for the hemorrhagic RD?
No, you don't actually need to do. If it is a smaller area that you want to dissect, then you can, even with the diathermy itself, you can melt off the choroid and the retina with the diathermy itself. So if it is such a large thing, then you have to use the cutter.
No, it's the entire area you are doing diathermy.
No, 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 no.
No, not
that-
the edges.
Yeah, at the borders.
So just one last thing, for any tips for finding that membrane, that posterior membrane, I mean, any particular...
Most of the times it is at the disc only.
No, in the funnel RD, the last case.
Yeah, last case. So most of the times it is at the disc, and what happens is the whole of the retina will be like that, and then there is this crumpling. It becomes like a flower inside. So if you are able to just reach the disc and remove the membrane, start the membrane removal from there, it will come in one piece. So you don't have to then search for the membranes.
And so in the same cases, there are subretinal membranes also. Which
Yeah,
are holding.
first you remove the subretinal membranes, and then you go
And
inside.
Any recommendations for identifying these subretinal things?
In
I mean,
this
sometimes
case,
it's
in
very
this case, because everything was so crumpled up, I could see everything. But sometimes you do have this difficulty because it's a partial giant retinal tear, and there is a lot of membranes there. Then you have to flip the retina and see those membranes and remove it.
Dr. Charu?
No, nice videos. The first case, what was the indication for the, what was the reason for the hemorrhagic RD?
It was PCV only.
Okay. No,
Yeah.
my only thing is you used a 27 gauge. So, and the 27 gauge backflash, I don't know with the clot, because the heme is usually very thick and clotted.
Yes.
Rather, sometimes we prefer 23 to 25.
Yes,
Yeah.
yes. I think I should have, because it took me a lot of time to remove that blood. I should have used, but actually, what happened is in our private practice, we just have one type of system available at one time, because investing in all the gauges is very difficult. So at that time, I had those 27 gauge instruments only, and I had to do with that. And in fact, if I had used a 23 gauge or even a 20 gauge, it would have been a little faster than what.
The other thing is, I mean, though, I agree we make a small retinotomy, but I mean, at least I would prefer some like supranasal or supratemporal rather
Yeah,
than inferior for the
yes.
small area to start draining the blood, since this was 360 degrees.
Yeah.
I mean, just as a, I mean, I guess it's a superior quadrant would be probably preferable to the inferior quadrant. I think this was infratemporal, I think you made.
I made almost temporal, and it actually depends where you can easily reach one thing. And because I knew that I had to enlarge the retinectomy, whatever happens, and I knew I had to. So even if you are not able to do with one single retinotomy, you can even create multiple holes, small holes, and then that also work fine.
Dr. Sangeet, in your second case, usually the vitrectomies are very difficult because the vitreous is very abnormal. So there apparently the indication was just a recurrent macular edema in your case. Would you have done something more to the tumor before you really resorted to a vitrectomy? Like
In the
addition of
time
more laser or a...
So she had already undergone, I think, 3 sittings of laser and 2 sittings of cryo. She had already undergone.
Gone.
Yeah. Not during the vitrectomy, earlier.
What was the IOP that you kept for the angioma excision at the time that you were, kind of excising it?
I generally operated 30, and I think I did not increase it any further.
For all your chorioretinectomies, you don't raise
No,
the
no,
IOP?
no, similar.
Not even transitorily?
No, only if the bleeding starts.
Thank you, Dr. Sangeet.
Thank you.